360 degrees of cortex removal. You are almost done over here and you feel you are very safe. You managed a very hard cataract. And can you just see what has happened while removing this cortex through the 12 o'clock? The posterior edge of the cannula has touched the PC and there is a PC rent. So even when you think that things are going well, this can happen. So what do? This is the plan B. There's no vitreous loss, but you can convert this flap into a posterior CCC with the specifically designed forceps. Now here there is no vitreous, so vitrectomy need not be done. This is a central PCC, and for surgeons who are used to doing a PCC, this is very good in a pediatric cataract. This is a well dilated pupil and a hard brown cataract. You're doing phacoemulsification after a central capsulorhexis. So it is hard. You can do a good phaco. You are doing a good phaco and most of the pieces are removed. And what remains here is the cortex. Again, this is a very good device to do cortex aspiration. This is a single port cannula and the AC maintainer. You polish the posterior capsule, which is very good. You put in the lens. You are very happy that you are doing a good job. And you are almost home because what is now required is just hydration. But please note what has happened while putting the posterior chamber IOL, sometimes one of the haptics or the stretch of the bag. So let's recap. While putting this IOL, you have done nothing wrong, but sometimes these type of situations do occur. The delivery was smooth. There is a oblong pear-shaped PC tear, but there is no vitreous. Everything is good. So not necessary that you have to go and mess around every time. You can leave this alone if there is no vitreous. This is the third patient where you are starting phacoemulsification. It's a corneal tunnel. You are doing phacoemulsification. Please don't go into the periphery. This can lead into complications. As you can see over here, the chamber is very, very unstable. Normally in this type of phaco machine, the chamber has to be very stable. Now, while doing something with the chopper, can you see the leak from the sleeve? The leak from the sleeve is causing the unstable chamber and hence the PCR. You need to know anterior vitrectomy and that also an automated one. So plan B is here. First do an automated vitrectomy. There is a huge nucleus piece and it is better to convert this into SICS. Either the main incision can be closed or you can do it through the same incision. Put in an IOL and then you have to suture this wound. You have to be very, very careful while putting the IOL. Here, actually, we should have gone with a 3-piece IOL. So the lesson to be learned over here is that you should have a 3-piece IOL also in the OT in case of such occurrences because you may not be able to put this lens. But if there is a bag available, then you can put this in the bag carefully without causing any problem. You can see these are some few vitreous stands. So always check the sleeve and the needle and the standby lens. Now this is a posterior polar cataract. Now even before you begin this case, you know that there is going to be probably a PC defect. And when you are doing cortex removal through the main incision, there is shallowing and there is some amount of giveaway which could have been prevented. So as the cortex is clean, you can see the vitreous. So anterior vitrectomy, now these type of patients, even without messing up, there could be a PC tear. So the plan B should be always ready in a PPC that you have to have a vitrectomy standby because whatever you see on slit lamp also may not be what you see on the table and there will be a defect in such type of patients. So you need to have a vitrectomy standby and not to enter via the main port while doing cortex removal. This appears to be a very soft cataract and you are trying to divide the first division, but the phaco piece does not have any hold, the phaco probe does not have any hold over the nucleus, there is no movement, you are not able to divide. So sometimes what you have to do is what we will see now. You are not able to phaco, whatever you do, you are not able, so maybe the power is not right. But here, this is the nucleus solute. You are trying to chop, but whenever such a situation occurs, I would suggest that wait, put in visco, assess the situation and then go back in. the nucleus, there is no followability of this nucleus, and hence you need to step back. This is edited, but you saw that we came out, we waited, and we did what was to be done. The pupil is fully dilated. You can lift the nucleus completely, as you can see over here, and then chop it. The pupil constricts because of your handling. So be very careful that nothing is going on behind the pupil. The nucleus is lifted up completely. So in many cases, you know, your finesse goes for a toss. You may not be able to do a stop and chop and everything like that. And sometimes be careful while lifting with a chopper. You can lift it with a dialer because a sharp chopper may cut through the PC, but you may have to change even your technique of phacoemulsification to give good results. All the time remembering that use of viscoelastic to protect the cornea, keeping the patient in mind first, keep a plan B always ready, and a standby surgeon, and if everything fails, leave it so that the patient gets the best results. Thank you so much. Thank you for the opportunity to present.
Thank you, Dr. Ragni Parekh, for the exchange of knowledge. Our next speaker is Dr. Prabhu Shankar. He is going to discuss about posterior polar cataract. Over to you, Dr. Prabhu Shankar.
Thanks, Dr. JP and Dr. Jason. Oh, yeah, play. நான் ஆப்ரேட் பண்ணிக்கிட்டுமேங்க. Yeah, posterior polar cataract is the most challenging cases during phaco. So always when you're planning a rexus, don't go try to make a large rexus. In case you have a PC rent, you have enough support for the IOL placement. So one basic thing is make a rexus around 5 mm, never hydrodissect. You can hydrodelineate, but even that's too risky. Suppose your hydrodelineation goes wrong, you might end up with hydrodissection. And this is an unedited video now I'm just showing. The patient around maybe 35 years old with a bilateral posterior polar cataract. So very soft nucleus. So I've not done hydrodissection. Since it's a very soft nucleus, I'm just going with very low aspiration. So basically in posterior polar cataract, never allow your anterior chamber to get decompressed. So gently keep aspirating because a very soft nucleus, it is no issues. So I'm just gently trying to nudge the nucleus part. See, very soft cataract, everything is coming down easily. So subincisional nucleus, you have to be very careful. So your second instrument plays a major role during posterior polar cataract, and never allow the eye to get depressed. Now you can see the posterior nucleus coming out very safely. So the most critical step in posterior polar is never come out of the anterior chamber with immediately inject sodium hyaluronate to the side port. This is the basic step you have to follow in a posterior polar cataract, and you will never have a PCR. So always never allow the eye to get decompressed, fill the bag, and now I come out now. So once you come out, it's easier now. So the cortical wash also, same thing, go do the cortex wash. And again, the second step again needs to be followed, go inside again with the second instrument, instead of the second through the side port, inject the sodium hyaluronate. Never try to do any PC polishing, never go near the PC at all, because anytime you can have a PC rent anytime during